So the Onyx1 study was a study designed to evaluate a complex group of patients who need to undergo PCI. So I'm talking about patients who are at high bleeding risk and who need to have stent implantation for stable, unstable coronary disease. We know these patients with long-term dual antiplatelet therapy are at high risk of bleeding, but they're also at a high ischemic risk if you shorten their dual antiplatelet therapy too short. So what we did in Onyx1 is we randomized 2,000 patients to either what has been in Europe the standard of care, the BioFreedom stent, or to the Onyx stent, which is a durable polymer stent with a better profile and better deliverability. And both groups of patients were given 1 month of DAPT. And after 1 month, either the aspirin or the P2Y12 inhibitor was stopped. And we then looked at 1 year at what the outcomes were. The main study findings showed that the two stents were equivalent and safe in these high bleeding risk patients with only 1 month of DAPT. But there were lots of other questions that we can and we need to answer from this trial. So we performed the sub-analysis to try and understand would there be any difference in outcomes if patients were left on aspirin versus a P2Y12 inhibitor? Now remember, when you do these sub-analyses, even if you pre-specify them, your study is not powered to find differences, and any differences you find are hypothesis generating and really should stimulate further analysis and further studies. In order to perform the sub-analysis, we put all the patients together, irrespective of stent type, and then we divided them up into whether they continued with aspirin from 1 to 12 months or P2Y12 inhibitor from 1 to 12 months, and then looked at clinical outcomes. An important thing is that the baseline characteristics were pretty different between the two groups. For example, in the P2Y12 group, there were more patients with atrial fibrillation, on anticoagulation, and with more criteria for high bleeding risk. However, when we looked at clinical outcomes and we looked at the primary outcome, which was again cardiac death, MI, stent thrombosis, between the two groups, there was no differences in the primary outcome. There was also no difference in target lesion revascularization, target lesion failure. We did see a difference though in cardiac death, and the incidence of cardiac death was higher in the group that continued P2Y12 inhibitors. Now, I'm not really certain why that is, because when you look at the other endpoints, individual endpoints that may contribute to cardiac death, like myocardial infarction, stent thrombosis, or bleeding, there were no significant differences between the groups. If anything, the P2Y12 group had a lower incidence of myocardial infarction. So it's not really clear to me why this difference is there. We did perform also a multivariable analysis to look for other predictors of the primary endpoint. And on the multivariable analysis, we did find that hypertension, chronic kidney disease were important predictors. Stent type was not, so it didn't matter what stent you were on. But once again, we found that the P2Y12 inhibitor was associated with the primary endpoint. The implications of the sub-analysis are that we probably need to study this factor, this variable better on what antiplatelet therapy to continue from 1 to 12 months when you discontinue. We assume, many of us, that it doesn't matter whether you take aspirin or P2Y12 inhibitor when you discontinue dual antiplatelet therapy. This analysis would suggest that maybe there are some differences that need to be explored further. We will try and, for the manuscript, really get more detail and try and really filter through the different groups, understand whether the group who's taking anticoagulation, which is more common in the P2Y12 inhibitor group, contributed. We also will add all the data from the Onyx1 CLEAR study, which is a single-arm registry that was performed in the United States, also with the Onyx stent and 30 days of DAPT. And I think hopefully with that data, it will give us a better insight into if there are differences and whether this warrants maybe a randomized trial to understand, should you continue aspirin or P2Y12 inhibitor when you shorten DAPT.